Hi, everyone. My name is Dr. Gail Roboz. I'm a professor of medicine and director of the leukemia program at Weill Cornell Medicine and the New York Presbyterian Hospital in New York City. It's my pleasure to review some data that we presented at the recent ASH meeting in Orlando, Florida, on Pivekimab sunirine in combination with venetoclax and azacitidine in unfit patients with newly diagnosed AML. So CD123 is an important target in AML. It's expressed on 93 to 97% of AML cases. And Pivekimab, or Pvec, is a first-in-class ADC, which is composed of a high-affinity anti-CD123 antibody and an IgN pseudodimer payload that alkylates DNA and causes single-stranded DNA breaks without cross-linking. The IgNs are actually designed to have high potency against cancer cells while demonstrating less toxicity to normal marrow progenitors. And in a prior interim analysis of a phase 1b/2 study in patients with CD123-positive AML, Pvec combined with Ven Aza showed very promising responses with a manageable safety profile. So in this report from ASH, we discussed the phase 1b/2 study with a focus on a preliminary subgroup analysis from a cohort of unfit patients with newly diagnosed AML who received triplet therapy. So here, again, the triplet azacitidine plus venetoclax plus Pvec was given to two cohorts of patients. In the first cohort, they had 14 days of venetoclax, and the second cohort, 28 days. And the key inclusion criteria were age over 18 with a confirmed diagnosis of CD123 positive AML. The confirmation was via local flow or IHC. Performance status of less than or equal to 1, and then for the expansion phase, unfit patients were defined as over 75 or under 75 with an ECOG performance status of 2 or 3, or greater than or equal to 1 defined comorbidities. And so there were a total of 76 untreated patients were enrolled in first-line cohorts. Of these, 49 met the strict criteria for unfitness. The primary endpoint was antileukemia activity, so CR rates, and secondary endpoints included things like MRD response and safety assessments. So looking at the patients treated, again, this is 49 patients in the unfit cohort. The majority of the patients were over 75. 73% of the patients were greater than or equal to 75 years. And in this group, the majority were also intermediate and adverse risk. So 20% intermediate and 51% adverse, and 35% of the patients had TP53 mutations. In cohort 1, the duration of venetoclax was 4.5 months with a wide range from 2 to 22 months. And in cohort 2, the duration of venetoclax was 5.7 months, again, with a wide range from 0.9 to 15 months of exposure. So moving to the summary of responses, they looked very good with 50% CR rate in cohort 1 and 67% in cohort 2. If you looked at a composite CR/CRI rate, it was 70% in cohort 1, again, cohort 1 being 14 days of venetoclax, 82% CR/CRI in cohort 2, with relatively rapid time to first response. So 0.9 months with a range of 0.7 to 2.6 months in cohort 1, and 1.2 months with a range of 0.6 to 4.9 in the second cohort. There was also a high rate of CR with MRD negativity of 80% in cohort 1 and 95% in cohort 2. Again, these were among the responders, those who attained MRD negativity, and the CR/CRI MRD responders were 83% in cohort 1 and 92% in cohort 2. There were interesting responses observed also in TP53 mutations. Again, the wild-type patients with a higher CR/CRI rate of 94%, but there were 53% responses, CR/CRI, in patients with TP53 mutations, obviously that representing a particularly difficult to treat subgroup and one that we always watch whenever there are responses. Looking at overall survival for the unfit patients, this is 12.4 months with 9.4 to non-reached, not reached as the range. 6-month range, a 6-month rate of overall survival was 84%, and 51% of the patients still alive at 12 months, with a duration of follow-up median 16.2 months. Among the TP53 wild-type patients, the overall response was not reached, and 75% of the patients at 12 months. And then among the TP53 mutated patients, overall survival median of 8.5 months, with a 12-month rate of 6%, again, lower than for the wild type, but still somewhat promising for TP53 mutated patients. Again, very difficult to treat subgroup, and certainly that subgroup is not served well by venetoclax and azacitidine alone. The safety summary showed that the primary reason for discontinuation of PVEC were progressive disease in 29%, stem cell transplant 16% of the patients, so the total of 8 patients, and AEs in only 2 patients, and there was no VOD of any grade seen across the study. Hematologic AEs were as expected, with significant myelosuppression from the regimen, in line with what is expected for venetoclax and azacitidine. So overall, in summary, there was a high rate of response, overall 63% and 80% CR/CRI in CD123 positive AML patients who were meeting strict criteria for unfitness. The triplet of venetoclax, azacitidine, and PVEC led to durable responses with a median duration of CR of 16.1 months, with a median follow-up of 16.2 months. Median overall survival was 12 months, with 8.5 months in patients with TP53 mutations and not reached in those without TP53. The conclusions of our team was that the therapy was overall well tolerated, with no unexpected toxicities or safety signal, and we felt that these were encouraging data, sufficiently encouraging to warrant ongoing investigation in a randomized trial. Thank you for your attention.